So we'll start straight away with the cases, and I'll start with two cases of similar problem. One is a 57-year-old postmenopausal lady, hypertensive, screen detected solid cystic lesion, right breast, 11 o'clock, 7 into 6 mm, which was seen on USG as well as on mammo, reported as BIRADS 3, 4A. No microcalcification seen on mammo, and examination was normal. Her mother also had CA breast. The other lady is 64 years, hypertensive again, screen detected pleomorphic microcalcification in the right breast, 9 o'clock position, BIRADS 4A. Ultrasound was normal. Last mammo of 2017 was also normal. Examination revealed a dense area which was tender on the opposite side. Same side did not show any abnormality. She also had a family history of colorectal cancer, prostate cancer, as well as RCC. Now, I have the films only of the second patient, so I won't be able to show the first one. These are the mammo films. And if you see, that's the microcal. That's here. And this is a magnified view, which is showing it slightly better. So what are the next steps, and can we start from one end, Dr. Manisha? For all of you, please, what is your next step for this patient?
Am I audible? Yeah. So you want my take on both the patients?
Both the patient, please. Yes.
Yeah, both are post-menopausal. And first we need to, and both have a clinical suspicion, clinical and imaging suspicion of malignancy. So we need to prove it and do a metastatic workup. These are the two major things that we need to see first, and then go on from that.
How do you want to prove?
I would do a true cut biopsy for both of them, image guided, obviously.
Okay.
Both look like they would be obvious on ultrasound. So a ultrasound guided biopsy would be possible in both of them.
The second one actually was not showing anything on ultrasound. Only the first one was showing. Second
It was
one,
only X-ray
ultrasound was normal.
mammography.
It was only on mammogram.
Okay. So probably the second one would need a stereotactic or a like mammo guided or a MRI guided biopsy if it is available.
Okay. So next, please.
I would agree with her. The second would require an MRI guided stereotactic.
Closer to the mic, please.
Hello.
Okay. So he says, I agree with Dr. Manisha. Next, sir, would you like to comment on this?
Yeah, I think first thing is to establish a diagnosis with a tissue. And in first case, looks obvious that lesion is visible. So a true cut will be of use. And second case, I feel you should have a better imaging. Probably MRI may be helpful here.
Okay.
Because you have to image it before you biopsy it. So a better imaging
Okay.
procedure.
So another opinion is that we should do MRI as well.
Because you have to visualize it before you take a tissue.
Okay. Dr. Shubham.
I largely agree with the same, that we need to do the triple assessment because in the second case, it's not
assessment, by and large, third part of the assessment you're saying, right?
Yeah, and because in the second patient, it's not visible on the ultrasound probably, and we are suspecting a strong family history. So that is why getting an MRI done for both the patients may be more worthwhile in the first patient because there is a significant family history in the second patient as well.
So MRI in the second patient actually did not show anything. I'll show only the report. I don't have the film, but MRI did not show anything.
We'll believe you.
Reported as BIRADS 2. Wow. So your other colleagues are wiser now, at least for the second patient.
Actually, I was going to agree with Dr. Shubham that we should go for MRI for the first.
I told you, MRI is normal for the second patient at least.
So we need to go do a true cut biopsy guided.
True cut biopsy.
Where the lesion
Dr.
is-
Shubham, true cut biopsy.
The question is, how would we localize the lesion? I would want a biopsy since
So
there is.
I think we have only one way now to localize is stereotaxy.
Yeah.
So with BIRADS 2, you want to go ahead actually?
That is MRI. This is BIRADS 4.
I would say because there is a discordance of the reports, between the mammography and the MRI, it would be better and in benefit of the patient to at least do a biopsy so that we are more sure and certain about.
There are two reasons why we should do it. First, this is a suspicious microcal. I hope everybody agrees here, whoever can see this. And secondly, more importantly, it was not there in 2017 mammogram.
Strong family history. and the mammography showing BI-RADS 4A lesion. So we cannot disregard 4A lesion only by looking at that MRI showing BI-RADS 2. So we must prove this, and we are seeing the lesion on the mammography. So true cut biopsy, I think, would be the first choice.
Okay, Kabra ji.
Actually, the first case, true cut biopsy won't be possible. 6 mm true cut hitting then going. So wire localization and mammogram of the sample. And the second case, obviously, the lesion is not visible, so we have to excise it and send for intra-op mammogram. That's the only option we have.
So you say both of them localize and excise.
Localize and excise for tissue diagnosis.
Okay.
Because 6 mm we cannot do true cut
Okay.
if it is not palpable.
In first case, no doubt, if we can target it by a USG guided, because
We
it
can,
is there,
we can.
we should be trying without an MRI also. We should be trying first by a USG guided biopsy if it is possible. If not possible, we should get an MRI done and proceed further with the biopsy accordingly. And in the second case, which is not localized, which is not visible on ultrasound, we have to go for a stereotactic biopsy.
Any other opinion from the house? So there are various opinions. MRI, many people have said, most of them have said true cut biopsy. One has said localize and excise both of them. And one is saying localize and excise one and true cut for the other, right, Dr. Satya?
Can I just add a point here about the sensitivity of MRI? It's really opposite, isn't it? Mammography is showing a BI-RADS 4 and MRI is not coinciding with it actually.
Only microcal may not be visible on MRI unless there is.
So that means what I mean to say is that if you have a suspicion on a mammography, should you routinely go for MRI or not? Is it less sensitive?
Okay, so that question is also one of the questions. Let's see, this is why mammogram is important. Many a times we see patients coming up with PET CT
And MRI.
sometimes MRI, but no mammogram. Biopsy also done, but no mammogram. So that is why mammogram, I think, is important for every patient. Any, ma'am, you wanted to say something?
What I wanted to say was that whenever you have a suspicious lesion, my take is, it's always better if you can make a biopsy, because you can do one surgery with a sentinel node. If you do a wire localization and excision, you need a second surgery. So as far as possible, if a biopsy can be done, ultrasound guided, mammographic guided, MR guided, only available in Vedanta, I think it's always better to make a biopsy and then plan your surgery. And for this microcalcification, I mean, I think you just said MRI is normal, but never mind. Mammographic cord biopsy or mammographic VAB, if somebody is doing it, and take the whole thing out and have a biopsy is always better, or a close follow-up.
Ma'am, why VAB over true cut? You mentioned VAB, you're the only one who has mentioned VAB. So why VAB and not true cut?
No, it is not the question of where. If you have the facility, if your radiologist is confident of doing a stereotactic core needle biopsy, you can do a core needle biopsy. If she feels or he feels that core is not possible, then of course the VAB is the possible. What madam wants to convey, or what I want to convey, that pre-treatment tissue diagnosis is very important. A new appearing microcals over the period of 2-3 years, I think we must suspect and do a biopsy, because it will save 2 surgeries. We can do a VAB or stereotactic biopsy, and if we feel all the microcals has come up, we can put a clip in that.
Yes. So even why I was asking VAB versus true cut, because the upgradation rate after VAB is practically 0, whereas after true cut there is still some upgradation possible, and you may end up with another surgery again. So even after doing a true cut, you may end up with another surgery. Anyways,
VAB is expensive as well.
Sorry.
Yes, it's quite expensive.
So there are many issues. Availability is again one more issue. So both had MRI. One was BI-RADS 4A, other surprisingly reported as BI-RADS 2. We did discuss with the radiologist, and they said, no, I can't see anything there. What we did, we discussed, at least for the first one, I said we will do a wire guided localization rather than doing a biopsy. The second one, option of VAB was given, but patient did not agree for it, and we actually did excise both of them after doing a wire guided localization. So these are the options that I had put, and almost everybody did mention one or the other except observation, which is obviously not an option in any of these patients. So this was the wire placed, and that's the specimen mammogram. Wire in at least in one view had gone beyond the microcal, in the other view was okay, and you can see that the margins are looking okay, and that's the biopsy. Both are DCIS. The first one is a 3 mm grade 1 cribriform solid, no necrosis. Closest margin is 4 mm, ERPR 10% and weak staining. Whereas the other one is a 5 mm intermediate grade cribriform papillary type. Margins again are clear and ERPR is 95%. What would be your adjuvant therapy, and is the margin adequate? The second one margin was more than 1 centimeter. The first one, the closest is 4 mm. Is margin adequate as per all of you?
Yes.
Both the cases? Fine.
I think more than 2 mm is.
More than 2 mm for DCIS is what is acceptable today, and no ink on tumor for invasive cancers. What about adjuvant therapy? Dr. Satyam?
It is DCIS, we will be proceeding for an adjuvant RT along with hormonal treatment.
Any difference of opinion? Sir, can we avoid radiation for any of these?
Yeah, a good surgery is sufficient for this. Radiation, why should you give a DCIS?
Sorry, please, louder, please.
I think I would avoid radiation in this case.
For both the patients?
Both there's no invasive malignancy in both cases. So a good excision, I mean,
RT is must in both the patient.
Because
For the first patient, since ERPR is 10%, I might give an option of not going ahead with hormonal, but definitely RT.
Okay. Any difference of opinion?
RT to both the cases, but looking at
this is
the
a-
hormone positivity in one of the case, and if it seems to be a low risk case, few cases you can avoid RT, but general practice is to give RT to all the patients.
This is a unique situation, sir.
I
They are saying
also-
give RT, and the radiation oncologist is saying not to give RT for both the patients.
Actually, what I would say is probably we need to discuss what the patient wishes. In view of the biopsy reports, there would always be an option of a mastectomy if the patient wants to avoid the radiation altogether. So that component also needs to be discussed along with other things. Definitely, these are low risk cases, but I would still probably err on the side of the patient is keen for the conservation to go ahead with radiation.
So as Dr. Puri mentioned, I think
I mean, I'm sorry
there is
about
a very small.
It's a small
cohort of
lesion,
patients where you can avoid RT in today's time with DCIS. There are more and more studies coming up where you probably may be able to avoid RT in more and more patients. But a low-grade tumor who is going to receive tamoxifen or any other hormone therapy, clear margins, small size, probably those are the patients where you may be able to avoid RT. But otherwise, even in those patients, the local recurrence rates are higher if you don't give RT, but in the very long run. So yes, to be fair, there are some patients who can avoid RT, but largely, if you say so, this was discussed in our tumor board, and again, two radiation oncologists had two different opinions.
such a small lesions we hardly see.
Yes, VN.
So what did in your case?
Well,
What
it was from,
did you give RT in this patient or
Less than
not?
6 or less than 7, the local recurrence rate is less than 5.
there was single university,
I mean,
University of South
doing
California, which
radiation
was
for the
doing this thing.
entire breast, you know.
So that's what I'm saying, ma'am. There is a small cohort of patients, and definitely one of them fits into it.
What did you do?
The first patient. So second patient, we have recommended RT. The first one, my personal opinion is avoid RT. Yeah, we don't have. Unfortunately, we don't have. So
NCCN recommends that RT should be
RT should
given.
be
You
given.
should consider RT
No,
only
NCCN
in a
has-
very small cohort of
Yes.
patients where, endocrine therapy is being given and very low risk features. Von News index can be used in those patients, so they can be, there we can avoid RT.
Have to wait for the Lord, Loris and Comet. Patience.
okay. Now, my question is, if you have a papillary lesion on ultrasound, which seemed to be the case in the first patient, it didn't turn out to be, but it seemed to be the case. What would be your initial management? The patient comes to you with an ultrasound, maybe mammo also done. Ultrasound is showing a papillary lesion. What is your first management for that patient? First investigation. So basically, I want to just highlight that our pathologists don't want a true cut, definitely don't want a true cut on a papillary lesion or a solid cystic lesion. They are wary of reporting even on WAP because they say the morphology gets distorted. They are very happy if we excise them, widely excise them and send it, the whole specimen is sent. So that's how it is. And I guess most of us are practicing that. Ma'am, you have a different opinion or?
Mentioning are possibly you're talking of dilated retroareolar duct with a papilloma, 95% being benign, 5% being malignant, but you need to excise it.
Yes.
So I agree with you. I would like to do a good excision surgically than doing a VAB. Actually, Jyoti prefers doing VAB on these, excising the whole thing. But I think a good surgery and a good pathology
Is
would
very
be in
important.
order. I mean, these are retroareolar papillomas, right?
Yes,
Not-
most of them turn out to be papillomas.
Dr. Kabra, one
Oh,
One
sorry.
more thing I think we should have discussed in the second patient especially. The second patient had a non-palpable, non-mammo detectable lesion.
No, it was detected on mammo.
It was mammo detected. It was not seen on ultrasound.
Yes.
So, and we do a biopsy and it turns out to be a DCIS. Are we sure that she doesn't have an invasive breast cancer which is not detectable at the present
Exactly,
investigations
absolutely
that she
right.
had?
That's why I said the upgradation rate of
Yes.
only a true cut is much higher as compared to a VAP.
So it would probably not be very safe to advise her not to have RT unless she opts for a mastectomy.
No.
No,
We
RT
have-
will be given
Sorry,
only after we have
no,
excised the
so you're
lesion.
saying that it is not a true cut biopsy. It is a wide excision biopsy. We have a margin clear. We have no other microcalcification anywhere else.
Yeah, but
I think
what
we have-
about multicentric disease?
No, it's not there. Right
It's
now,
not
it is not
multicentric.
there. We have done MRI also, so we don't have a proof to say that we should go for mastectomy. Not for this patient. That in my opinion would be an overkill.
So did these patients end up with radiation in your center, both of them?
First one, second one, yes. First one still deciding. Recently operated. Both of them operated a month ago.
First one, she's ERPR is just 10%. I think she must go
She's
for RT
deciding.
in this
She's
case.
deciding. She's deciding. She has met a radiation oncologist, discussed everything, but she's still deciding. Not yet started. So I told her, I'll tell you. I told her that you have a very low risk of reoccurrence, but there is an increased risk if you don't take radiation. However, with the kind of histology you have, if you are not keen, you can avoid it. The rest, I said, you please discuss with the radiation oncologist and take a call.
Now, the radiation oncologist, as per NCCN guidelines, second patient doesn't require any radiation. Wide excision is good enough.
And the first one,
First one also, it's a small lesion, wide excision, good enough. NCCN guideline clearly says it doesn't require.
NCCN actually says give radiation to all DCIS. It says give radiation to all DCIS.
If not adequately excised.
It has mentioned certain exceptions, yes, in the text. But as far as guidelines go, they say radiate all. Anyways, we move on to our third patient. Is a 31-year-old premenopausal unmarried Iraqi lady. Had a excision of a breast lump, lower outer quadrant of the right breast in 2019, fibroadenoma. She didn't have any slide or block available, so we don't know what it was, but we presume that it is fibroadenoma. In May 2022, she presented with a breast lump, which was clinically 3 by 2.5, hard nodular, 9 to 10 o'clock, so adjacent quadrant. And there was another smaller lump inferior to it. Mammo and USG mammo showed very dense breast, but a lesion was seen in upper outer quadrant, which was highly suspicious. And she's very keen on breast conservation. Does the panel agree that if we have to conserve, there are two lumps palpable, at least one seen, and ultrasound, both are seen? Do we move with MRI if we are to offer conservation, or you feel that conservation should not be offered at all at this stage?
I think the second lump is very close.
So anyways, first those who feel that conservation can be done. Okay, so everybody feels. So we do MRI or we move ahead with this dense breast and ultrasound? We should do MRI. Okay, fine. So this is how the clinical picture looked like. I just marked the lumps. There are two lumps, and that scar also you can see just below that, which was a previous scar of fibroadenoma excision. MRI was done, showed two lesions. The largest one was 2.6 centimeter. There were few sub-centimeter nodes, but looking normal on MRI. And true cut biopsy was ERPR strongly positive and HER2 positive on FISH. IHC was equivocal. What would be your management? Or you need PET CT or you don't need PET CT? Dr. Manisha, you wanted
I
to
would
raise this
be-
question of PET
I
CT.
would be comfortable without a PET CT. This is the largest size of the lesion is 2 centimeter, 2.5 centimeter.
5, yes.
So PET CT wouldn't be recommended, but most of these patients would come to me already a PET CT with a PET CT being done by somebody or other. So, but I would be comfortable if it has not been done. I would be comfortable with without a PET CT. C can be conserved, and obviously the true cut biopsy has already been done.
Okay,
If
so-
I can take it out, as you showed the picture, I can take it out with a single incision. I think C would be a good candidate for breast conservation, and probably would require some, because he's 31-year-old with a dense breast, maybe would require a level 1 oncoplasty.
So we did end up doing a PET CT. This is how it was. The MRI also is showing the upper and the lower pictures are showing the two lesions which were adjacent to each other. Now, what are the treatment options? These are the 4 options that I can think of, and each one of you please select one and let us know. Maybe we can start from this side now, Dr. Satyam.
Patient is ERPR positive, triple negative.
No, HER2 negative, triple positive.
Triple positive.
HER2 positive, triple positive. I
Triple
said.
positive.
All 3 positive. ERPR strong, HER2 positive. She has 2 lesions. The largest one is 2.6. Nodes on ultrasound, mammogram, or sorry, and MRI, PET scan. Everything is okay.
You told one of the lesions was pirate 1.
No,
that is
no. That was something else on the other side.
I'll be offering upfront BCS plus oncoplasty.
Okay. So BCS with oncoplasty, Dr. Ajit.
Yeah, so patient, I think from Iraq, and I don't think so she would be having insurance. So offering
No,
new
that we are
adjuvant.
presuming. That we are presuming.
No,
Please don't
so
presume right now.
unless patient has money to pay for trastuzumab
let us
later
go
on.
by guidelines right now.
So,
or-
so we have to discuss with the patient. If the patient is not willing for that, at either adjuvant trastuzumab immediacy, then obviously upfront surgery would be feasible.
And if she is willing,
Better. If she is willing, then definitely HER2 we will have to. Yeah, yeah.
Okay.
She is HER2 positive.
Yes.
So, and T2 lesions. So NCCN these days recommend
Early
that,
T2.
yeah, even T2 lesions should be, they should consider for this thing, new adjuvant chemotherapy,
Okay.
followed by BCS.
So considering that there are 2 lesions and that there is an adjacent scar, to give good cost messages, it would be better to go for NACT followed by BCS and oncoplasty.
Okay.
So the patient was keen for a conservation. So definitely the first 2 options are out, I would say, for mastectomy. This patient will
The
be,
patient may be keen for conservation, but you feel it is not safe for the patient, right?
no, it's feasible for this patient.
Many a times patients are keen, but we can't offer because we feel it is not safe. So that's why I've put those options.
So it would be feasible as per my understanding of the images. This patient will definitely need chemotherapy. If we can give neoadjuvant chemotherapy, that will be my first preference. But if,
And the reason for giving neoadjuvant is?
because it's HER2 positive disease and she's a young patient.
Okay.
If for some reason she's not keen for a neoadjuvant chemotherapy, then upfront surgery, BCS is also feasible for this patient, I feel.
It has been seen that the HER2 positive and triple negative breast cancers, they respond very well to the chemotherapies upfront. And PCR can be an indicator of long-term survival. So even the early lesions T2 and NEC and plus are considered for neoadjuvant chemotherapies these days.
I think upfront surgery in the form of conservation should be a good option because patient is operable and you can very well do a conservation. Why should you start chemotherapy neoadjuvant first? I think, Dr. Shyam, what will you do in this patient? Will you offer neoadjuvant?
I'll ask them later. Let the 2 people finish.
See, let's make the thing simple,
Let the
let's-
panel finish. I'll ask them definitely this question.
So surgery first, of course, remove it and do a good reconstruction, then offer, send within a
So
3 to 4 weeks to surgeon.
Two surgeries and 3 NSCTs, 1 plus minus depending on the affordability, right? No, we are not discussing affordability here right now. Yes. No, because he said if the patient can afford trastuzumab, I would prefer neoadjuvant.
I think NSCT should be offered, followed by BCS plus oncoplasty, and it would also require preoperative placement also for
That's a very good
localization.
point. Placement for both the lesions.
Yes.
Both the lesions.
I already gave my opinion.
No, you didn't.
BCS, yes,
No, acha, okay. BCS, but upfront BCS or after NSCT?
upfront BCS.
Okay, can I ask the house to raise hand for upfront surgery? Very few. Only surgeons are raising. Only surgeons.
No, I think Vedant, she is 31. She is HER2 positive.
Yes, sir.
There are 2 lesions. One lesion is 2.6 centimeter. The other lesion is also very nearby. So actually the total area of abnormality is almost 4 centimeter. I think this patient should be given NSCT plus targeted therapy. We clip both the lesions and then we later on, whatever she opts, whether BCS or mastectomy. But I think this patient from today's guidelines, HER2 positive disease more than 2 centimeter, this patient fits in for neoadjuvant treatment. Whether she can afford dual block, whether she can afford single block, that's a matter of economics, that Herceptin plus pertuzumab or Herceptin alone. But these patients should be given neoadjuvant therapy followed by surgery.
So you said that it's a total area of around 4 centimeters. Now suppose this was only single lesion, upper outer quadrant.
Correct.
So yes, you did answer your question later on.
Can I think one of the MRI said it's 1.8. So do you take 1.8 or 2.3? And the Sara Tulane, Dr. Agarwal can correct me, Sara Tulane paper of de-escalating the hormonal treatment, the anti-HER2 treatment with just Taxol alone for lesions less than 3 centimeter. You can de-escalate rather than giving TCH or AC followed by say. So if the lesion is 2 centimeter and less than 2, solitary lesion. If there are 10 solitary lesions of less than 2, it's T1. It's not T2. So to my mind, upfront surgery, no lymph node involvement, upfront surgery laterally placed, so easy to excise.
Ma'am, it's T2 and it is not
You
solitary.
said one of the MRI is
26 mm,
1.8.
26 mm.
2.6.
If it's more than 2, yes, you can give her neoadjuvant chemo, but it's less than
Not
2.
much time left.
You can
maybe,
de-escalate.
maybe one medical oncologist also. They haven't. Okay, Dr. Randeep.
Ma'am is right. Sara Tulana's paper APT trial was 3 centimeter inclusion, but ma'am, the fine print is that only 7% of the patients were 2 to 3 centimeter. 93% of the patients were 2 centimeters. So that's why the data has evolved in that way. Coming to the comment of whether we give NSCT or why we give NSCT is in a HR positive 2 to 3 centimeter lesion. Node negative is that we tend to achieve past CR, and we believe that if we achieve past CR, we will achieve at least a 10-12% DFS. And if we are not able to achieve past CR and we add Catherine data, that is the adjuvant CATSALA, we achieve another 11% DFS. I can't comment about OS, but yes, we do feel that if we are escalating the therapy bit by bit, we may be able to achieve 15 to 20% of invasive disease survival
I
advantage.
agree with you. This is something which has to be considered, but at the same time, when you are using asking for either pertuzumab or TDM1, then definitely question of affordability would come for large number of our patients. And if a patient is not able to afford TDM1, then I really don't know whether we are offering any advantage.
We are talking about disease-free survival.
That's what I said.
So that's
Dr.
another
Randeep
question you need
accepted
to-
that only DFS is improving. He has said that. Right. So I also
Dr.
wanted
Vedant,
to.
any role of Ki-67 in deciding it, which you have not mentioned in the biopsy?
No, I don't think I'll decide based on that. So I also wanted to discuss fertility preservation, but I don't think we have time. Just wanted to say that for such younger ladies who are either unmarried or married but nulliparous, desirous of having a child, we must discuss this. Whether they express it or not, we should bring it up ourselves. There is one more very quickly. Can I just go through this, Dr. Paul? 2 minutes. Okay, this is a young lady had an ultrasound in January, was told that it is all okay, you go back. In April, another ultrasound shows a irregular lesion, 2 centimeters. There's no family history. True cut biopsy was done outside before doing anything else, which was IDCA grade 1, ERPR strongly positive, HER2 negative, and a reasonably low KI. Mammo was done when she came to us, and this is the mammo, which is dense. So we did MRI as well, which was showing a solitary lesion. Again, I've put role of PET here, but I think we have discussed, so I'm not going to go there. Normal looking notes, just 1 more minute. Yes, now what is your opinion, surgeons? Upfront surgery. Now this lady has a very small breast. It's a largish lesion, would require some amount of skin also to be sacrificed. Upfront surgery, and obviously she wants BCS, which she's suitable for. Upfront BCS versus neoadjuvant. If neoadjuvant, then what? Chemo or hormone? Upfront. So yes, so there was a dimpling, no puckering, I would say. There was a dimpling because there is a large area of the tumor which was pulling the breast. No skin involvement. Skin was not involved anywhere. You would prefer neoadjuvant?
Upfront BCS with oncoplasty.
With oncoplasty. So neoadjuvant hormone or chemo? Chemo. She is ERPR strong positive, HER2 negative, KI low, may not respond very well to chemo. Dr. Shefali is smiling. Dr. Shefali, please. What is the percentage of very good response that she will achieve BCS according to Dr. Shubham? Shubham's satisfaction.
I mean, in these high risk subgroups where it is TNBC or HER2, I mean, DFS can be taken as a very well accepted surrogate
No, we are
marker.
not discussing that, please. Sorry, I don't have time about this patient.
All right. So can you repeat that question, please?
This is a 2 centimeter lesion, 2.6
Yeah.
centimeter.
Yeah.
Which is strong hormone positive, KI low, HER2 negative, grade 1.
Yeah.
Everybody wants to operate for
Hormone positive.
oncoplasty because it is a small breast and she would definitely need almost a quadrant will go.
Right.
But Dr. Shubham says that I want to give neoadjuvant chemotherapy.
Right.
My question is, what are the chances that this is going to so significantly decrease that a big oncoplasty?
So in strong hormone positive, if you wish to achieve a PAT-CR in a hormone positive, so it is not very common. So it's to the tune of say 18 to 20%.
And even
not more than that.
K67 is low, so they are not going to respond
The
that well
problem
to
here
the
is
chemotherapy.
I said breast size is very small. So even if you achieve some kind of response, you will end up using a volume replacement.
In a hormone positive, or for that matter, till now in every. Yeah, absolutely. So PAT-CR and hormone positive is not more than 15 to.
So anyways, we finally did surgery first with a TDAP, and this is the photograph. Sentinel node, I am not discussing because it has already been discussed and debated also. Thank you very much. Thank you very much, all the panelists.